Dr. Shadman, let's switch gears now and move to relapse disease. You spoke a lot about CLL14. Maybe we can transition into the relapse setting and application of venetoclax in the relapse setting. The trial that led to approval for venetoclax rituximab in the relapse setting was the MURANO trial. And that's been updated recently. I wonder if you could highlight the information from that update.
Sure. So MURANO was the study that brought venetoclax-based therapy in combination with rituximab here to the relapse setting for CLL. Again, a chemo-free regimen that was time limited, in this case 2 years. So patients were randomized to either venetoclax and rituximab, and here venetoclax was started first, and a patient received that treatment for 2 years. It was not an MRD guided study. Again, everybody stopped at 2 years if they could tolerate and if they were responsive to treatment. And the standard arm for this study was bendamustine rituximab, again, a very commonly used regimen. So initially when we got the results, and so I should mention that 40% or around 40% of patients had an abnormal P53, again, kind of distributed between the two arms, either deletion or mutation. The study showed both PFS and overall survival advantage for venetoclax and rituximab, and I believe a PFS of around 86% versus 35% at the initial report. Again, another situation where achieving an MRD negative state at the end of treatment is really important for prognostic information, and because that translates to a longer progression-free survival. So at the last ASH meeting in 2019, we had a 4-year follow-up of MURANO study presented by Dr. Seymour, and we continue to see that improved PFS for the VEN-R arm, and here we were at 57% versus 5%. Again, I think the most important probably piece of that presentation or data is that, again, looking very specifically here at MURANO, we have very clear numbers of what would be the PFS in patients who have an undetectable MRD, and again, that's UMRD4, and with the median 22 months of being off therapy, 86% of patients who had undetectable MRD at the end of treatment are progression-free, versus 60% in patients who are considered low MRD, which is between 10 to -2 and 4, and patients who had more disease burden, more than 10 to -2, they were like at 7%. So again, clearly, what you achieve at the end of treatment gives you very valuable information on what to expect in terms of clinical progression. So another important data that came out of this long-term follow-up, which kind of goes back to the question that you asked Dr. Burke before, is do we use MRD in clinical practice? And I guess in my case, my official answer would be no. I try to go with 1 year and 2 years of therapy, but really I have been looking, because one data that came out of this MURANO long-term follow-up was that the kinetic of the MRD actually matters. When they looked at the patients who had detectable MRD at the end of treatment, they seem to have been this rising MRD level before end of therapy. So in a way, you can kind of predict, if you start checking a little bit earlier, and if you see that the rate or the level of detectable CLL is going up, you know that your patient won't achieve an undetectable state at the end of 2 years, and probably if you continue, you know, not only you don't see an improvement, you see like more disease. So do I use that? I have in number of patients started looking a little bit before end of therapy, and if I see that their level is going down, and if I can treat them for 26 months instead of 24 and stop when they're at the undetectable MRD state, I do it. And totally, this is not based on any data, but I think most of us try to create some for ourselves, and that's kind of my small project. But really, this is again another discussion that I have with patients. I tell them the whole idea of you going on this therapy is to have a fixed duration therapy. So if I want to continue and chase an MRD, maybe, you know, that's not the most smart idea. But again, if I see that trend, and if I feel that by treating 2 more months and I get an undetectable state, then I think some patients feel much more comfortable stopping treatment if they know that they don't have any detectable disease using what we have in terms of the MRD assessment tools. But again, this study, the longer follow-up of the study shows that the treatment is effective. Again, the time-limited chemo-free in the relapse space, using only one of the novel agents. We talked a lot about combinations, and it's great to use our best drugs upfront and hopefully cure patients. But I also think about the situation where what if that patient stops responding to both? And I think having a combination of venetoclax with a non-BTK therapy is kind of reassuring, because you have a very reliable drug as your backup plan. But this was the MURANO basically summary and follow-up.
Great, thank you.